Good evening, everyone. Thanks for joining us tonight. So let's get started. I don't want to take too much time behind because we've got a packed schedule here to cover a lot of good information. First, I just want to thank Park City Hip Knee for sponsoring this. It's fantastic that they're encouraging this continued education. And as some places are starting to shut down, the need for this education is obviously very important. We're going to talk about revision arthroplasty today. And it's going to cover a whole host of areas, looking at infection, complicated cases with the hip and the knee. So we've got everything covered here, which is nice. I'm Antonia Chen. I'm at Brigham and Women's Hospital, if you couldn't tell from my background. And we're going to kick it off today, starting with a discussion on depression and PJI by Dr. Jennings.
Thank you, everybody. So I have an interesting topic here. It's probably not a hot topic in orthopedic surgery, and some of you may not have thought of this, but I hope that after this talk, it may open your eyes a little bit to maybe some questions that you have about it, or questions perhaps you should be asking your patients to help with care in the future. I'll tell all the residents and fellows that are on this call and maybe young attendings, I was taught as a young surgeon that careful what you publish on, because you may get trapped in that and always talk on it. So I promise I do operate. I'm sure a lot of you may know me as the cannabis or pot guy, which I talk about quite a bit. It looks like I'll be talking about depression for a little while. So I hope you enjoy this. I really want to thank my co-author, specifically Dr. Hegde, who was our fellow last year. He's at Johns Hopkins now. He's just did a fantastic job putting this data together. As you see, there's quite a bit. It's fairly complicated. And my research coordinator, Roseanne Johnson, who is the backbone to my practice, as well as my partners. And also thank my partners at Colorado Joint Replacement. So here are my disclosures. I promise there's none significant for antidepressants or depressive symptoms. So I think we all know the topic in total knee arthroplasty. If you see the patient come in who's severely depressed or has anxiety or any psychological distress, we know that their outcomes in total knee arthroplasty, primary total knee, is certainly less than ideal compared to those who don't have those disorders. The literature really has not, I think, dived in enough into what we're going to talk about, specifically with periprosthetic infections. My practice is heavy with infection. Probably about 15 to 20% of my practice is infection-based based on our catch area. So I had noticed probably several years ago that I was probably missing something, because I have patients come in I did a fantastic job with, and their knee or hip felt great, but yet they were down in the dumps, and I really didn't do a great job in asking the appropriate questions or perhaps preoperatively screening, and you're stuck at 6 or 8 weeks shuffling through and calling primary cares and trying to get these patients better, not just physically, but mentally. And so our purpose was to look at the incidence of clinic depression as well as depressive symptoms. We'll help define that for you. And then also look at function afterwards in this patient population. So our methods, we had 76 patients with periprosthetic infections, and you can see here they're fairly equally divided over a 10-year period for those who met the inclusion criteria. This was between 2008 and 2018, and we chose 1 year as a minimum follow-up so we could at least see what their physical and functional scores were after their intervention. So we defined depression as somebody not only had the clinical diagnosis, but they also has to be on one antidepressive medication. That would require us looking in the chart. So we have an internal medicine team who does a much better job of documentation than we do as orthopedic surgeons, and typically see these patients preoperatively for us. We looked at their VR12 scores, the mental and physical composite scores. And we actually had to look in the cancer literature to look at the mental composite scores for these patients, and anything under 42 was described as depressive symptoms. So that was our surrogate here in this study for our statistical analysis in this cohort. This is just a brief description of 4 areas that we looked at for our revisions for our aseptic match group. And again, here's our cohort defined as the DARE with 39 patients and 37 in the 2-stage. I think our findings are fairly interesting, but fairly predictable. About 25% of the patients in the DARE group had a clinical diagnosis of depression preoperatively, and almost a third of the patients in the 2-stage group. As you may expect, if somebody came in with a periprosthetic infection, particularly undergoing a 2-stage intervention, their mental scores as well as physical function would be less than those of the aseptic revisions. However, at 1 year, we did not find that difference persisted, albeit I will readily admit that with our cohort, our numbers, it's not as large as we might like it. So we could be underpowered for that, but it's certainly something to look at further down the road. If we take a peek at the actual depressive symptoms, again, these are patients that don't have a clinical diagnosis of depression per se, but they come in with a very low composite score in the VR12. There's 4 times higher depressive symptoms in the 2-stage group than our aseptic revision match cohort. But we didn't find differences post-operatively at 1 year. We didn't see differences in the DARE group either. So this is basically for the 2-stage group. If those patients had residual symptoms post-operatively, as you might expect, their physical and functional scores at 1 year actually suffered as well. If we looked at the DARE group separately, we really find the same things. I won't regurgitate these numbers, but I think what you should take away from this slide is these patients, when they come in, if they have depressive symptoms and they have either preoperatively on a medication or their scores are suggesting so, you see that when they have the depressive symptoms, their physical scores afterwards are significantly less, both with the change they have postoperatively. And it's really important to realize that if those symptoms persist, that this will affect their long-term function. Our numbers here show this consistently throughout as well. So again, conclusions here from this, I think the incidence is probably higher than we think. It may even be higher than this if we had a larger cohort. In the general population is 5 to 9%. If you look at the primaries is 10 to 11 and aseptic revisions is 13 to 14. We showed here, 25 and 30% rate in our study. So I think it's probably likely patients aren't coming in expecting this. They have their knee or hip done, they're diagnosed, which is a life-changing event. There's a prolonged period of disability in this patient cohort as well. So again, 4 times higher rate of this depressive symptoms in the 2-stage, that's a real number. If you look at that, it doesn't necessarily correlate with patients who have depression preoperatively. So these patients may have been well functioning, they get the diagnosis, and they really drop in the tank from a mental standpoint. And so our conclusions are, I do think that this can contribute to inferior functional outcomes long-term. I think us as orthopedic surgeons need to be on the lookout, and we need to consider adding screening tools and interventions for this patient population as needed. Thanks for your attention. I appreciate it. I'm happy to answer questions later during the discussion.
Fantastic. Thanks for a great presentation, Jason. That was very sobering when it comes to looking at our population. So there'll definitely be some questions about that later on as well. I'll be the next presentation talking about infection. I'm talking about the diagnosis and prevention of infection, not from a study perspective, but just general overview. This could be a topic that lasts an hour or a day or multiple days, but in this case, we're going to be doing it in 6 short minutes or 8 short minutes. And there you go. So I want to talk about this diagnosis and prevention of PJI. These are my disclosures, none of which are directly relevant to this. So what it really comes to when it comes to, it's a diagnosis and prevention of infections. When you prevent them, the idea is I really want to focus on modifiable risk factors, not risk factors that cannot be modified. And this is a calculator developed out of the Rothman Institute involving over 40,000 joints and over 1,000 PJI. And it demonstrated that there are a bunch of areas, let me go back one. There's a bunch of areas here where you can see that we can affect our patients to improve their outcomes and reduce the risk of infection, which is the first panel on the right. Some things we can't change. We can't change their type of insurance per se, or the surgery type if they're getting a hip or a knee or a primary revision or any previous surgeries they've had, but we can tackle their comorbidities such as diabetes, anemia, and things like that. So again, this is a topic that I could cover all day long, but I'm going to reduce it down to one slide. We want to prevent periprosthetic joint infections by reducing MSSA and MRSA colonization. Now, how to do this is actually very controversial in different practices, and I'd love to survey the panel later on to see what they do in their own practice. Some people treat prophylactically and don't want to worry about testing because things can get caught in the mix of things. Some people test everyone so we can determine who gets vancomycin and who gets gets ANSEF. Reduce obesity. Our cutoff here is a BMI less than 40. And in places like the UK, if you have a BMI greater than 35, you can't undergo surgery. You want to improve malnutrition. So looking at metrics such as albumin and vitamin D, these are things that we never got preoperatively in patients or paid attention to it preoperatively in patients, but now we do. And we actually will correct them with protein shakes that are low in sugar, or vitamin D. If they're low, then we can use high dose up to 50,000 units once to twice a week, and then do that for at least 4 weeks prior to surgery. You also want to optimize diabetic patients as well. Hemoglobin A1C cutoff in our institution is 8, and a glucose has to be less than 200. Anesthesiologists are very wary to undergo anesthesia if I've had patients who come in with 400 and they have to cancel the cases because of that. I said we take away everything fun, and Jason can obviously speak more to the marijuana side of things, but I'm talking about cigarette smoking. And cigarette smoking, I reduce it 4 to 6 weeks prior to surgery. I tell them to quit smoking. And once they quit smoking, they give us a call 2 weeks. They tell us a call when they quit smoking. We test them 2 weeks later, and we test for nicotine and cotinine. And then once that is cleared, then they can get onto the surgical schedule. But I won't put them on the surgical schedule until prior to that. And you also want to reduce alcohol abuse. And again, I stop 4 to 6 weeks prior to surgery. So again, remove everything fun, smoking and alcohol at that time. When it comes to diagnosing infection, there's been multiple definitions developed from here. Dr. Jay Parvizi is really the one that pioneered this start with at the Musculoskeletal Infection Society, where he developed major and minor criteria with a team of experts, with one major criteria being the sinus tract, or 2 positive cultures taken at 2 separate times, or 3 out of 5 minor criteria, which includes elevated ESR and CRP. They have to be combined, not just one or the other, although we know CRP is more sensitive. This is for chronic infections, but white blood cells count greater than 3,000, polymorphonucleosides greater than 80%, frozen sections positive, and 1 positive culture. This was when the time when purulence was removed. And the idea is that you don't need a positive culture to have an infection, which was different than most people was thinking at that time, and most people's publications in the past when it came to defining PJI. And this is an example of a sinus tract. If I call it the positive metal sign. If you can see that, you've got a sinus tract. So how do you improve culture yield? You take patients off their antibiotics for at least 2 weeks, avoid swabs and Gram stain, give tissue at all possible times or fluid. When you do the fluid, look for white blood cell counts, polymorphonucleosides, cultures, and I always get crystals in every single one of mine. For tissue cultures, hold them for a minimum of 14 days to get slow growing organisms such as P. acnes. Ideally for fungal, if you suspect fungus or mycobacteria, if you can hold it for 6 weeks, that's ideal. And if you're using fluid, you can use pediatric blood culture vials. The idea is you can take this, it's a smaller area and it can actually grow the culture. How many times do you pull a sample and it sits around in clinic all day long until the end of the day before it gets picked up by a courier and then finally goes in? In that time frame, the bacteria can die. So you put these in the blood culture vials and they actually proliferate and grow, which is what we want because we want to see that. An international consensus meeting came up with the definition of infection in 2013 with the addition of leukocyte esterase, which happens here. You can see here on the right-hand side. If it's negative, it's yellow. If it's positive, it's purple. And the idea is we used to take urine and dip it, take these sticks and dip it in and then look at the numbers. I used to remember doing that in the emergency room as an intern. So that's an area that was added as another marker of white blood cell count. These are a bunch of biomarkers that are listed here. One of them is interleukin 6, and there's actually a quick lateral test that's available in Germany, but we don't have it here in the United States. And then we all have heard of alpha defensin before too, which is yet another mechanism by which the neutrophils release alpha defensin. So your body's response to an organism is the release of alpha defensin, which is then measured indirectly into the synovial fluid and has high sensitivity and specificity. And there's also the version that's using a dipstick that's now available in some labs here. By putting the fluid on it, you can actually see a plus or minus kind of like a pregnancy test of orthopedics. The D-dimer test is another one. This is available in all of our hospitals, which is nice. It's an acute phase reactant that's elevated in pulmonary embolisms. And at 850 cutoff, there's high sensitivity and specificity, not just for the diagnosis of infection, but reimplantation. So it should come down by the time it's ready to be reimplanted. Again, it's already readily available, but the problem is it is non-specific and non-validated. And then D-dimer was found to be inferior to plasma fibrinogen also, which is available in our hospitals when it comes to the diagnosis of infection. The last definition, the most recent one was 2018, the ICM criteria for infection. You can look at ESR. So this is a point system here. So the first two, when they say infected, have not changed. Positive metal signs, see a sinus that's positive, or 2 positive cultures separate times. If your CRP or D-dimer elevated, that's 2 points. So in between. If your ESR is elevated, it's only 1 point. It's not as sensitive or specific. If you have either elevated white blood cell count or leukocyte esterase or alpha defensin, you get 3 points for that. If you have polymorphonucleocytes that's elevated, that's 2 points. A single positive culture is 2 points. Positive histology, 3 points. And then positive intraoperative purulence, but cannot be metal on metal, is also 3 points. So it's high. So molecular methods, we all heard of PCR, especially now this is very popular secondary to COVID testing and all the PCR they're doing there. You can visualize it with fluorescence in situ. And then next generation sequencing to be able to see what is mapped against a library, and 90% of culture negatives are positive on next generation sequencing. And finally, you have methylene blue, where you can actually see the biofilm if diluted. So in the future, we need point of care tests that are low cost, easy to use, excellent accuracy, identify organism and antibiotic resistance profiles. You want to have serum markers for reimplantation because we can't always get fluid from the joint, and you want to prevent infections before they occur. Thank you very much. So the good news is we're still on time here, and I invite Thorsten Seyler to speak about irrigation solutions. He's a pro at this. I've heard him speak before on this, and he is very good at this. So without further ado, Thorsten.
Thanks. Perfect. So I follow these two very depressive topics, something that is equally depressive. So we're going to talk a little bit about antiseptics and irrigation solutions for periparasitic joint infections. Similar to what Antonia said, I can go on and talk for hours about that topic, but we're going to just talk about the relevant things. Really nothing to disclose that is relevant for this talk. We're going to start off with a little bit of a historical perspective. Using antiseptics in surgery is not a new concept, right? That goes back to the early 1900s. And if you look at this, there's candidates that we still use, the iodine Deckey solution. If you look at the table, this is from February 12, 1919. So they already used that back then. This is Alexander Fleming's classic article on this. So what's the rationale for antiseptics in surgery? Very simple, right? The contamination starts at the time of the surgery, right? Wound contamination is the leading cause of periparasitic joint infection. So using these makes sense. And there's a variety of irrigation solutions available in the US, right? It's dealer's choice. You pick what you want. Some of them are better than others, and they have advantages and disadvantages. So we're going to talk about the most commonly used one and data around this. I'm going to start off with chlorhexidine, right? Chlorhexidine is synthesized in the 1950s. It has a high antibacterial activity, really low toxicity, and has been considered generally as a very safe antiseptic. It comes in a bottle. It's not super expensive. It costs around $80 for half a liter. And you can use it and don't have to worry about it. And at low concentration, which this is, it is bacteriostatic, right? It doesn't reach bactericidal concentration. It's a multi-step process, and it attacks the membrane of the bacteria. Now, what you should keep in mind is with chlorhexidine, it has a wide antibacterial range, but it doesn't work for everything. So if you look at this, and if you look at time that is relevant to what we do in surgery, I would say like a 1 minute exposure time. You look at this on the left side, just look at the Candida. The log reduction is really good. You have a 4 log reduction for Candida. If you look on the right side, look at the strep, at the staph. Chlorhexidine really isn't that great for those. But again, chlorhexidine has a wide range. Okay, let's talk about some paper around this. There is some stuff. This is the Mayo Clinic. Scott still looking at chlorhexidine antiseptic irrigation and then eradication staph epi bio. But that's in vitro study, right? And if you look at this, was the iodine required much higher concentration and long exposure time to get rid of the biofilm compared to chlorhexidine. Another paper published in Arthroplasty today looking at chlorhexidine against the normal and a betadine. They didn't find this clinical study. They didn't find a difference. But if you look at the numbers, I would argue that this study probably was underpowered. But again, they didn't find a difference with three groups. This is an interesting paper. It is it's meta-analysis, more bendied. There's not much in the literature. There's 2 papers on the chlorhexidine. One, I quote the clinical paper, but the conclusion there is that it is beneficial to use over the control groups. Now, betadine, if you look at this, perhaps the oldest solution for wound disinfection, right? Gold solution back there. It is, without doubt, considered the best studied antiseptic if you look in the literature. It's an unpleasant odor, it stains the tissue areas around, it's painful in open wounds, it can trigger anaphylaxis of iodine. Iodine poisoning is rare with this, and the antimicrobial activity is determined by the free iodine in the solution. If you look at this all in arthroplasty at least started with a paper that came out of Rush paper looking at betadine for 3 minutes at the end of a wound closure, primary total joint, for the significant reduction in infection rate. They followed up that study with a prospective randomized study looking at lavage for acute prosthetic joint infection, same concentration, same protocol against reduction in the infection rate. This is again more direct study looking at the same meta-analysis looking at povidone iodine. Obviously, there's more literature available, and if you look at similar to chlorhexidine, it's efficient in preventing infection. There's more recent study coming out of the Mayo Clinic looking at large retrospective studies saying that it is not both in the revision setting and primary. Moving on to the chlorine compound, the Deckey solution has been around in the 1800s. It's one of those compounds to one of the oldest disinfection solutions to treat. It has reported a lot of things have reported points. So, and the other limitation is cytotoxicity. There's one study out there that obviously promoted this back in the 1940s that is equally good in its own osteomyelitis. But if you look at the joint temperature musculoskeletal wounds, no therapeutic effect using Deckey solution. Hydrogen peroxide, again, nature's own expectant, present in everybody's mouth. It kills via radical attacks the membranes, again, but creatively negatives become positives. Right? The good thing is synergistic with povidone. Hydrogen peroxide, if you look at this in the literature, it's using this in isolation. It's always with betadine. If you look at the literature available, there is enough literature, especially some literature and some of the joint literature that support this, but you cannot say it because of the hydrogen peroxide because it got never used in isolation. Finally, or almost there, acetic acid, vinegar, has been around since early 1900s, initially used to treat more wounds and shown to be effective against bacillus. Infections of 5% greater can lead to itching, pain, consistent with chemical burns. There are some concerns about corrosive nature of an acid that doesn't exist until 10 to 30% acetic acid, which you never use clinically. Okay, acetic acid literature, look at this. If you treat at 0.5% or 1% of acetic acid, it really completely eradicates Pseudomonas biofilms. If you look at Staph biofilms, we need to go to 1% to get this. Another paper, they looking at their 3% acetic acid for 20 minutes. I don't have time to soak my wound 20 minutes, which is work, so that wouldn't work. They showed. And this is perhaps, for me, the biggest thing is that it really works against Porous, Pseudomonas, as bacteria, all gram-negative. They're really hard to treat. But if you look at the Staph aureus, Staph epi, it really doesn't work for that. MRSA, E. coli, Enterococcus, acetic acid is not a good option. So this that we did Montana State, looking at Irrigation, which is a chlorhexidine, 0.35 betadine, which is Greg's protocol, and back to Shua, which is enzyme called chloride with acetic acid. If you look at it, that really isn't that effective for all bacteria. Betadine has a broad spectrum, but not high log reduction. Acetabular does a little bit better in comparison here. So in summary, resistance to antiseptics except Deckey solutions is rare. Not all antiseptics are the same. So CHG and codeine are probably the most studied. So develop a protocol that uses them and follow them. It means antiseptic, the time, the application, the order. Keep in mind, antiseptics are potent agents that have the capacity not to only kill the organism, they can also kill healthy tissues. And antiseptics can interact, they can form toxic byproducts. So keep this in mind, there's a nice thing out there too. Thank you.
Thorsten, thank you. It was the clearest thing I think we heard you say. But that said, it was quite well done. Your internet connection was a little bit spotty, but your slides are really helpful, so that was good. And we'll have more questions and discussion about irrigation pollution because, again, I'd like to hear what people are doing in their own practice. So we started with depression, mental health when it comes to PJI. So it behooves to follow the brain. So the next one is pain management. Start with the brain. Dr. Mathis is going to be presenting this.
Thank you. And thank you for the invitation to the Park City Hip and Knee meeting. I appreciate this. So we're going to talk about something different. Pain management, start with the brain. And I was approached a year and a half ago by some researchers at our institution in Houston at the University of Texas, Houston Medical School, about some research they were doing and were we interested in collaborating. And then I became very interested in this, and I'll share with you where this is going. I have no disclosures relevant to this research. So the current standard of taking care of knee osteoarthritis is pharmacologic approaches, the non-operative treatment, and these produce significant adverse events, as we all know. And knee osteoarthritis pain is characterized by alterations in central pain processing. And neuroimaging studies show increased pain-related brain activation in people with knee osteoarthritis. So it's a good model to look at this phenomenon. And there's a growing interest in non-pharmacological interventions targeting pain-related brain modulation. So only 40 to 60% of patients have favorable outcomes from pharmacologic treatments. And studies show that opiates, antidepressants, and topical anesthetics have limited long-term effectiveness. And current pharmacologic options have little or no effect on the mechanisms that are underlying chronic pain. Central sensitization is a main mechanism underlying chronic pain, and giving people opiates may actually increase centralization, as we've all seen in the chronic opiate ingesting patient who comes in for surgery and tells you they have a high pain tolerance. It's actually very, very low. And recent alternative approaches such as neuromodulation techniques, and I'm going to explain that here in just a minute, have been used to alleviate pain, but also revert the maladaptive plasticity of the brain, and may also be used to enhance the effects of other behavioral therapies, such as mindfulness-based meditation. And I'll show you our work that we're doing on that. So I'm going to talk to you about an intervention called transcranial direct current stimulation. And this is a treatment that modulates spontaneous neuronal activity and can generate long-term neuroplastic changes. And numerous therapeutic trials are showing significant clinical effects, especially when this is combined with other behavioral therapies. So the principles are you apply a weak direct electric current to the head in a non-invasive and painless manner, and it leads to modulation of the potentials of neurons and alteration of the endogenous excitability of this targeted brain tissue. The European chapter of the International Federation of Clinical Neurophysiology recommends that the stimulation with the anode be placed over the primary motor cortex, contralateral to the pain side, and the cathode over the supraorbital region, contralateral to the M1 placement. This stimulation with the anode over the primary motor cortex is believed to produce analgesic effects by modulating pain processing pathways, and recent brain imaging studies report a reliable cortical and subcortical neurophysiologic response to this direct current stimulation with the anode over the primary motor cortex and the cathode over the supraorbital region. And I'll show you some work that our group did in Houston that shows this. So we published this paper, Changes in Experimental Pain Sensitivity by using this home-based, remotely supervised transcranial direct current stimulation in the Journal of Pain Medicine last month. And this pilot study showed 30 patients aged 50 to 85 years of age were randomized, and these cranial electrical stimulation devices were preset at 0.1 milliamps at the frequency of 0.5 hertz. People wore them 60 minutes a day for 2 weeks, and you can't see it, at least on my screen, but we measured heat pain sensitivity, the threshold, and their tolerance, and then measured the condition pain management and the pressure point threshold, which is using a monofilament nylon probe that you see down in the bottom right there. The results from this showed that the visual analog scores, if you look at pre-cranial electrical stimulation, 55, the scale was from 0 to 100. Post-cranial stimulation is 24. The WOMAC pain, their heat pain tolerance, their heat pain threshold, and punctate pain are all significantly changed by this intervention. Things we don't know are how long does this last? Is it a 3-month? Is it 6 months? How long do they have a decrease in this pain that they're feeling? So in other words, we are increasing people's pain threshold by doing this intervention. And so we demonstrated that this home-based self-administered cranial electrical stimulation reduced the clinical pain severity in older adults with knee osteoarthritis without any serious adverse events. And this is a double-blinded study. The patients didn't know whether they were getting a sham hat that they wore at their home, and the researchers doing the test didn't know at all, and only someone not connected to the study unblinded all the data and revealed it to us. So we've got some current ongoing studies with much larger samples and well-designed randomized controlled trials to validate this and extend these findings. And we can show you what some of these trials are in our early results here. So one of the trials we're doing is a double-blinded sham-controlled study to investigate combining the effects of this cranial electrical stimulation with mindfulness meditation at home. And one group is getting a sham electrical stimulation device and sham meditation, and the other group is actually getting the real meditation video and the real intervention. And we've got a recorded device that patients are given with this device. And then we match time giving instructions in the sham meditation intervention to that other group. And when you look at this, the numeric rating scale change, you see significant changes in that, the WOMAC changes, the pressure point tolerance changes, the condition pain modulation, that's the CPM change, and the cold pain change, their ability to withstand their hand being plunged in ice water, are all significantly different when the group gets this active intervention. So what exactly is happening? And so by looking at this with infrared technology, you can see that we are actually increasing hemoglobin oxygenation in this area of the brain. And the patients not receiving the active treatment, the oxyhemoglobin level is not increased. And so to our knowledge, this is the first study that shows combining the effects of cranial electrical stimulation and meditation investigated by using this intervention reveals the increased blood flow. So we showed that 10 sessions of this home-based cranial stimulation compared with meditation for 20 minutes once a day with real-time remote supervision was feasible and beneficial in alleviating chronic pain, osteoarthritis-related clinical symptoms, and experimental pain sensitivity in the clinic without adverse side effects in these older adults with knee osteoarthritis. And we've got continuing studies going on with over 200 patients now. One of the things that I think is going to be our next trial after we finish these is if we are increasing people's pain tolerance with this intervention, that we do it in a randomized controlled way preoperatively and look at folks about to undergo a total knee replacement. And my hypothesis is that that group will take fewer pain medications, report lower pain scores, and possibly rehab faster. So I'll keep you posted with where this heads. But thank you very much for the invitation to speak.
Thanks for sharing interesting information. It's one of those things, it's an area that we don't read a lot on, and yet it impacts our patients so greatly. So thanks so much. So what I'd like to say here too is to introduce two special guests with us here. Dr. Bolognese and Dr. Hofmann are going to present the prestigious Aaron A. Hofmann Resident Award. And I think it's really important for us to recognize our trainees and what they do. And it's encouraging. I remember winning my first research award as a resident, and that spurred me on to do more research, for better or for worse. So thanks so much, guys.
Thank you. Thanks, Antonia. Thanks for the job you're doing tonight and the other speakers. And I know the boss is on here as well.
I'm just here to look good. That's all.
Yeah. Yes, sir. As always. I do want to take a minute to recognize, obviously, the person the award's named for, and Aaron, and all he has done to support education. As Antonia said, I mean, it's things like this that can help sort of spark careers. And Aaron's done a lot of academic support. Folks at our shop know how much he's done to support a Duke institution as well. And this is just one of the many things he has done to support education and adult reconstruction. So we did have, as we do for when these meetings are live, this sort of a poster award approach. Okay, here we go. So here are our poster award recipients. So now the way these are selected are done with a panel from key faculty. There has to be sort of removal and recusal of those folks where there's a conflict of interest, or I certainly would have been involved and voted for one of the Duke guys. So I'm letting the word out early. The two Duke guys, you're out. Okay, and I apologize to you guys if you're on, but you had great papers. And so did Dr. Drisman and Dr. Ringhart. Their papers and posters were excellent. But the award winner was Dr. David Deckey from the Mayo Clinic, Arizona. It was actually a great abstract. It looked at over 200 patients and cannabinoid use. Now, I get a little bit worried that Jennings had something to do with this, but he didn't. I couldn't find his name on the abstract, but I did read, looking at SANE scores and sort of the efficacy or improvement gained from using CBD products, whether it was oral or topical preoperatively. So I think we should all give Dr. Deckey a round of applause, if we can, virtual applause, and congratulate him on his award named in the boss's honor. And thanks for submitting. And boss, thank you again for this and all the other things you've done. Boss, any comments before you start?
No, I'm really looking forward to hearing the full presentation. I read the abstract, and I wonder if there's a reason that Arizona just voted for marijuana products to be legalized now commercially and recreationally. So I don't know if this paper has anything to do with that, but we'll find out.
All right. Well, I guess I'll pass it on to Dr. Deckey. Thanks again for all of the participants and folks that submitted posters.
Awesome. Thank you so much. Let me advance. Well, good evening. My name is Dave Deckey. I'm one of the residents at Mayo Clinic, Arizona. Just wanted to start off by thanking Park City Hip and Knee Foundation for this opportunity to present our research. But additionally, I would like to thank my co-authors, Drs. Nina Lara, Matt Goldbranson, Jeff Hasselbrock, Dr. Josh Bingham, and Dr. Mark Spangel for their help and involvement in this project. And finally, I'd like to express our profound gratitude to Pragna Carlo Pudi and Shreya Shandak for their help in collecting and tabulating all of the patient survey responses. So my talk today is titled The Prevalence of Cannabinoid Use in Hip and Knee Osteoarthritis. Let's see here. Perfect. Thank you. I have no disclosures. And so before I wanted to jump into the findings that we had specifically, I wanted to give a little background on CBD itself. So cannabis comes from the plant Cannabis sativa, and this single plant originates all of the compounds patients tell us they use. And so the active ingredients are cannabinoids, which work by augmenting the body's endogenous cannabinoid systems, primarily through the CB1 and CB2 receptors in both the central and peripheral nervous systems. And these receptors play roles in modulating nociception as well as inflammatory pathways, among other mechanisms. And the two primary cannabinoids are THC and CBD, and they have drastically different effects. And the ratio of THC to CBD varies immensely between different strains of cannabis sativa. So we can proceed there. Perfect. So what about hemp? Where does hemp come up in all of this? So hemp is actually the same plant as the marijuana plant. It just has to be less than 0.3% THC. And so how does that factor into all of this? Well, we can go to the next slide. And prior to 2014, hemp still fell under the Schedule I drug classification. And between 2014 and 2018, there was a series of farm bills that were passed that allowed universities as well as the Department of Agriculture to start conducting pilot research projects. And ultimately, hemp is now legal in all 50 states and not FDA regulated. And this has subsequently allowed and contributed to this boom in CBD availability. So we can proceed to the next slide. And ultimately, the legalization of hemp in the US and the mass marketing of CBD products has led to the widespread use of these products by consumers. At this point, clinical evidence supporting or refuting the use of CBD is largely absent for the treatment of musculoskeletal pain, and particularly pain related to osteoarthritis. However, despite this, the fact that you can buy CBD at practically any gas station at this point has led to more of our patients experimenting with these products in order to get some relief from their pain. And at this point, we didn't really know who was using CBD nor what our patients actually thought about it. Anecdotally, we've had a lot of patients come to clinic and say, hey, why didn't you ever tell me that CBD would be this amazing pain reliever? And so we felt it was necessary to do a prospective study just to answer these questions, looking at just basically prevalence and who's using these products. So ultimately, the purpose of our study was to report the prevalence as well as the subjective efficacy of CBD products in patients with symptomatic hip and knee osteoarthritis. To do this, we performed a prospective study of 200 consecutive patients who presented with painful hip or knee osteoarthritis at their initial evaluation with a total joint arthroplasty surgeon at a large academic center. Patients with prior arthroplasty in the joint in question were excluded, and a 21 question survey was administered that assessed the use of CBD in these patients, their perceived pain, and as well as the effectiveness of the CBD products, as well as other non-surgical treatment modalities. This survey utilized SANE scores, which are 0 to 100. Demographic factors were obtained via chart review, and 2 independent reviewers categorized all their radiographs based on either the Tonus or Kellgren-Lawrence scale for hip and knee osteoarthritis. And then descriptive statistics were used to characterize the data. Of the 200 patients, 80 were hip osteoarthritis, 108 were knee, and then 12 were presenting with both. 66% were female, and the average age was 67 years of age. There's actually a relatively even distribution of hip and knee osteoarthritis severities based on the radiographs for both hips and knees. So interestingly, 24% of patients, all comers, reported use of CBD products prior to their presentation. Move on to the next slide. And then we broke up the patients into 2 different groups, basically patients who had reported CBD use and those who hadn't. Interestingly, the average presenting SANE score for a non-CBD user was 50.8 compared to 41.3 among CBD users. Thus, CBD users reported significantly worse pain and function compared to non-CBD users with a p-value of 0.012. That was corroborated by higher VAS scores reported in CBD users at 6.6, significantly higher than 5.7 in non-CBD users. Here we compared the use of other conservative treatments in either group. CBD users at baseline used NSAIDs at a significantly higher rate than non-CBD users, but possibly suggesting that their pain was greater at baseline, thus prompting them to try CBD as NSAIDs and other modalities just weren't sufficient. Also, interestingly, we found that overall in the total population, 8% of participants had tried marijuana for their pain. More specifically, CBD users were more were significantly more likely to have tried marijuana than non-users. And at this point, when we were collecting the data for the study, recreational marijuana was actually not yet legal, although it did just become legal in Arizona. So we can proceed on. Ultimately, another question that we as physicians, would like to know is, where are they getting it? Where are they hearing about it? So 60% of people actually reported that they learned about CBD through friends, and then 67% of people actually purchased the CBD directly from a dispensary. And then oral tinctures and topical applications are actually the most commonly used forms at 43 and 36% respectively. So overall, we report a 24% incidence of CBD use among patients presenting with hip and knee osteoarthritis. And from this data, from this preliminary study, there doesn't appear to be a significant perceived benefit of CBD use compared to non-use, as patients who use CBD reported significantly worse SANE as well as VAS scores than non-users at baseline. However, this may be confounded by higher use of CBD products in patients who actually had worse pain to begin with. And so thus we're trying to attempt to find an alternative pain reliever. So I think ultimately follow-up studies are needed to assess these findings. And I think ultimately a randomized controlled trial comparing placebo to NSAIDs to CBD for the conservative treatment of hip and knee osteoarthritis is ultimately warranted. And yeah, thank you so much.
So we could probably spend the next, again, hours and hours going through questions. But Dr. Deckey, that was a great presentation. If you were to do this randomized controlled trial that you're talking about, which type of CBD would you place in that clinical trial?
So that's I'm unmuted. So that's actually a really good question, and one of our follow-up studies that we're looking at in a different subset of patients, we were actually collecting different brands, and there wasn't any one specific brand that has been like prevalent. And so I think that would be one of the first steps in trying to identify a laboratory-based CBD that has consistently the same percentage of CBD in it that is reliable, because that's definitely, one of the other difficulties when just looking at prevalence data and just patient-reported outcomes. When they're buying, you can buy CBD from any drugs or any drugstore or any gas station at this point. There's no uniform amount of CBD in these products, and as they're like fish oil or any other over-the-counter medication that's not FDA, or a supplement that's not FDA approved or monitored, there's no control. So I think ultimately trying to identify, to answer your question, basically trying to find the most common ones and taking it to a lab. And we were actually working with ASU to do a mass spec to identify one that has the most consistent levels of CBD is sort of our next step in that process.
Trying to compete with Dr. Jennings. I can see that now. So for Dr. Jennings, we're going to bring it back to you when it comes to depression. How do you think the rates of PJ are going to change post-COVID when people have been locked up in their houses for months and months and months and probably getting depressed? Do you think that's going to make an impact? And should we modify that risk factor prior to surgery for these patients?
It's a fantastic question. I actually was talking about that with my internal medicine physician today, because I was talking about this talk and we were actually looking at some other things with depression. We've brought it up. It would be a very interesting cohort. I think you'd have to do multi-center. Maybe some of the folks on this call, we could get together, look at our data and see if anything did increase. We obviously had shutdown. We'd have to look at numbers, so we'd probably need more folks. But I think the interesting thing is to not just primary knee, but if you take these patients' revision, they're going to take a big hit already based on our data, albeit I readily admit we need more numbers. But in the setting of COVID, they may even be lower than they would have been. So it's kind of maybe the double hit phenomenon that you see with certain disease processes. So it's a very interesting question, and I'd be happy to entertain a multi-center study if anyone wants to do that down the road.
I like the ideas that are being generated here. Dr. Seyler, your presentation definitely covered a lot of different irrigation solutions. And I know that you answered someone in the Q&A, but I think it'd be worth discussing. Is there a good order as to when to use the irrigation solutions and why you use the orders that you do? And does that affect the biofilm in different ways?
Yes, so that's a good question. I don't think there's data on the right order. I think, or the order that I use, and I answered this in the, I don't know if everybody saw that, I use acetic acid first, then I let it sit, wash it out with normal saline, use the witch's brew, which is betadine combined with hydrogen peroxide. The order or the rationale behind it is acetic acid has a little bit better penetration into a biofilm. So using that first and then giving the second hit with betadine to me makes sense. That's the rationale why I use it that way. But I don't think there's a literature or paper that shows a specific order is better than another.
Great question. The last one, Dr. Mathis, is what can we orthopedic surgeons take for us? How can we, how do we address catastrophizers? Should we not operate on them? Can we optimize them? What can we do in our patients?
Well, you know, this is an experimental intervention, this transcranial electrical stimulation. So I'm not recommending anyone go out and start putting electrodes on their patients' heads. But I think it is very exciting. I've never seen anything that you could do that caused the patient no side effects, no pain. And 2 weeks, 3 weeks after this intervention, when you're testing them in this lab, and we unblinded the data, it was clear that people that actually got this and not the sham intervention actually had a higher pain tolerance. So I think it's exciting. We're starting with knee osteoarthritis, but whether it goes to chronic low back pain, shoulder, name a painful intervention that we're about to do, that we do it to patients before they have the surgery, and it may enhance recoveries. And if after surgery they've got symptoms, that we can do something that's non-addictive, painless, inexpensive. I mean, it's kind of exciting. We just don't know. This is all, you know, really the infancy of this work. And so the federal government has given us 2 grants to look at this. And so I think they're very interested to see where we go with this.
Fantastic. Well, thank you for all the panelists in the first section. I learned from all your speakers, which is fantastic. We're going to focus
Can I squeeze in a quick question, please? And that I tried to put it in the chat room, but I don't know how to submit it, so it just stayed there in the chat room. But the question always comes up about betadine not being sterile. So some people are using the sterile betadine pack that comes in the spinal kits. We found a source for betadine sterile, and it costs like $1.60 per pack. But is that a problem? Maybe Seyler can answer that question. I thought our hip infection rate went up when we started washing out our hips with betadine that was just in the bottle. And then I found out that's not sterile. So is it a lot to do about nothing, or is that a concern?
So most of the irrigation solutions, if you look at FDA approval, don't have to be sterile per se. They don't have a secondary treatment. So if you look at this, the only ones that are available sterile is the acetic acid by Baxter and the Irricept. I'm not aware of a betadine product that is sterile. If you reach out to the company, they're supposed to change their label. And maybe Antonia knows more than I do, but I'm not aware of sterile betadine.
Yeah, I will send you the link for sterile betadine, which I discovered in Virginia about a month ago. So
Remember at the Park City Symposium, we had Matt Abdel talking about, and I think this was 2 years ago, Aaron, that they had cultured Pseudomonas out of non-sterile betadine at the Mayo Clinic. So we changed based on his talk. I went back, and the ophthalmologists have sterile betadine. I don't know what we're paying for it. We're using it now at our institution. I'm going to reach out to you, Aaron, because I'd like to know where you're getting it so inexpensively.
At that same meeting, Ken, this is Shawn Hocker, that he also presented a poster that showed that it didn't improve infection rates, the betadine irrigation.
Shawn, you're right. They published 2 papers in JBJS, but it's interesting. I think Dave Lewallen is on to comment on this. They showed in both series that they looked at that it's not effective, but they're still using it in all their cases. At least that's what Nick, who was the first author in these papers, and our fellow was last year, is what he communicated to us. So would love to hear what their experience is and what they're doing right now.
More to be done and more to learn from this. So thanks, guys. We're going to move on to the section on knees. And we kicked off, Dr. Hocker just asked the question on complicated primary knees.
Well, thank you very much. I may be the first panelist tonight that will adhere to the PCHK 10 rule slide prospect for presentation, but looking forward to hearing comments and enjoy the talks to date. So I was given a talk about complicated primary total knees. And so when somebody gives a talk, you need to give your surgical bias or preference. So when I talk about what I do and how I approach deformity and correction, I am a measured resection person. So for our gap balancers, so I'm approaching it from my slant or bias. So please understand that. And then I have no disclosures that are relevant to this talk. So going forward, I look at complicated deformity the same as I do uncomplicated deformity. Knee replacement is essentially a soft tissue procedure. So our osteotomies or bone cuts are made to try to present balancing of our soft tissues. In the deformity or complicated primary knee setting, it's important that we use conservative bone cuts. I'd much rather have residual defects on either the medial or lateral tibial plateau versus trying to chase deformity with a completely resurfaced cut, because often you will unlock hidden ligamentous instability through your correction, and you want to avoid the snow tie or poly to try to get balancing. I look at soft tissue releases in 3 planes. The coronal plane is really dealing with the collaterals. The sagittal plane is posterior capsule and often improving contracture, especially flexion contractures. And then the axial plane, we're looking at patellar tracking, and it also has influence in the mid-flexion instability. When I look at joint line preservation, often when we start looking at deformities and we start treating bone changes, we have the introduction of changing the joint line, and this has consequences for range of motion, flexion, and engagement in the patella and deep flexion. And then the patellofemoral tracking, we want to make sure that I am thinking about patellar prosthetic positioning and the size of it, plus or minus any potential lateral release. So if we go in, I look at it in 2 different planes. So we think about it, I think of the difficult varus knee. And so here, your reconstruction centered around the medial collateral ligament. Often this requires a deep fiber MCL release because this type of deformity and contracture can produce things that are difficult to get an axial alignment that you're trying to achieve. So in this scenario, I've been taught that accepting more proximal tibia varus, which doesn't mean your overall construct is in varus, but you're just producing less valgus for your surgical reconstruction, can often help your balancing significantly in varus deformity. And then when you're doing your releases, it's important for me that I do my that I do my soft tissue releases through trials and not laminar spreaders or tensioners. So if you don't have a simile to your final construct, often your releases are going to be overzealous, and that you may be looking at your polys that are much thicker than you want to have your final construct to be. This is one scenario when you're looking at an x-ray that looks varus, but it's actually chronic cruciate deficiencies where you have medial subluxation. This is a scenario that the knee actually balances like a valgus knee. And so if you look at the course of the MCL on the deformity on the right, it's tenting over the medial femoral condyle, which is now subluxed off the tibia. This is the same scenario as a valgus deformity where your MCL is stretched. And so here you want to make sure that you take really, really conservative bone cuts. So if you can see the proximal tibial little defect on the right, that's still present on the reconstructive x-ray on the left, where I almost did no bone resurfacing, but still used a thicker poly than I normally do. And so medial subluxation in a varus scenario often balances like a valgus knee. So just be aware of that. And so the second type of difficult primary is the difficult valgus. And so here, what I tend to look at is that through osteotomies, I like to correct my valgus deformity first. And so we're going to look at trying to tension the MCL, but using conservative bone cuts to achieve that. If you chase the lateral defect in the tibial plateau, you're going to make a proximal tibial resection that's going to put you much more distal than you would like. This then produces undersized tibia and a larger poly. And so all your reconstruction should be really based on your medial compartment. That's the only reliable resection depth that you can use in this setting. Also, when you're chasing the MCL, know that you're going to have an extension gap mismatch. So from the get-go, almost all my valgus deformities have 2 additional millimeters of resection on the distal femur to help accommodate the thickened tibial component that you're using to find mid-flexion stability. And that normally I use a posterior condylar reference to find tensioning for the mid-flexion gap on varus knees. On valgus knees, I found Whitesign's lines is much more predictable for developing mid-flexion stability, but it also gives you the added bonus of patellofemoral tracking, since often these have lateral subluxation problems with the patellofemoral joint. And then the medial compartment in terms of depth and slope is going to be much more predictable than trying to make any kind of inference off your lateral tibial defect. And so that resection, I will often accept continued lateral tibial plateau deformity and build up from it versus trying to cut down on the lateral side. And so in this scenario, the worse it gets, the more you need to be prepared to bring a revision type prosthesis. Often if I go into a valgus knee that's a tweener, I'll use a system that can convert from a primary to a constrained without changing instrumentation or changing systems completely. I normally make my bone resections to correct the deformity and then start releasing through the trials, starting front to back. So IT band, popliteus, sometimes the lateral collateral ligament is contracted enough that it requires at least some recession. In this scenario, because you're bringing the tibia back around and you're trying to tension the midflexion, putting a smaller patellar button, but putting it superior on your bone resection of the patella allows for deeper flexion, so your patellar component does not engage into the joint because you are altering the joint line slightly through this correction. And then I don't knee jerk to a lateral release on the patella. It's the last thing I do if all of the other bells and whistles have failed. And in this scenario, when you have a deformity like this, augment using screw rebarb to help with the tibial defect, but maintaining a joint line and constraint was needed to get stability. And then post-traumatic hardware, this is where newer technologies, including navigation and customized blocks, have been helpful. You develop a mechanical axis from the center of the hip to the center of the ankle. In this scenario, it's often tempting that you see an x-ray, you want to remove everything you see. You need to remove just what you need to do. So limiting your potential space for infection and pooling is important. So here, you may think that you need to take everything out. And if you do, I'd recommend doing it in staged fashion. but you only need to take out what you need to do. And soft tissue is also the most important consideration, and make sure that you plan your incisions carefully. And so in this scenario, we were able to use the medial incision only, avoid the lateral one, could remove just the hardware that was necessary for the femoral component, did not have to open the lateral side to extend it proximal to get all the hardware above. And we use navigation because of the loss of the medullary canal. So extra articular deformity, the long and short of it is that don't be a hero. If there's going to be a scenario where you can improve the outcome, limit infection, and do it in this two-stage fashion, by all means do it. So here, you're not going to be able to correct this through an intra-articular reconstruction. Fix the deformity above, correct the leg length deformity that was created from this varus malunion, and then reconstruct your nail around your nail. So here, you've lengthened the leg that's now more normal. You're going to have a better kinematic because of the joint line preservation. And then through navigation, I don't have to remove the nail. It essentially is a biological rebarb to help prevent any future difficulties. And then lastly, if you do all these steps, hopefully we get back to 2019 where you can celebrate your heroic efforts without mass and social distancing. Thank you.
Those are times we're all looking forward to, that's for sure. So thanks for that talk on difficult primaries. I'm going to switch topics to 1 versus 2 stage revision total knee arthroplasty, and this is done for infection. So going from one end of the spectrum to the other end of the spectrum. All right, my disclosures again, nothing relevant to this talk here. So what is the best way to treat these patients? What if someone showed up into your clinic like this with PJI? Do you treat them with the 1 stage? Do you treat them with a 2 stage? I mean, what would you do if it was your own parent, or if it was you? What would you want to have done? And the idea here is you have 3 main areas of treatment when it comes to periprosthetic joint infection: irrigation debridement, 1 stage exchange, and 2 stage exchange. The efficacy of the 2 stage is high, but the morbidity is high with it too, because you're taking everything out and then reimplanting sometimes 3 months, sometimes even later down the road, if they even do get reimplanted. So it's a hard decision to make, and they do overlap in some areas. And in some patients, or in most patients, it's not a clear-cut answer. So the benefits of 2 stage exchange is something that we're all familiar with here. High infection control rates up to 100% by some articles, successful eradication of atypical and resistant organisms like MRSA, which we're seeing more and more of in our communities, unfortunately. Longer follow-up and survivorship rates of 85% at 5 years and 78% at 10 years are quite good. When a patient hears that, that's something that they might want to do in their own lives if they're infected. And historically, they have better, it's for 2 stage infection control than 1 stage and DARE. But it's still the gold standard treatment globally. It's still most commonly here used in the United States, as well as Asia and the Pacific. And in Europe is the area they probably use 1 stage the most. Now, more and more surgeons here in the United States are starting to do 1 stage. And I'm sure for those who are tuning in, the residents here, they've seen a 1 stage at least, but it's an involved process. So when should 2 stage exchange be used? Use them when patients are septic, don't have soft tissue coverage, infected with resistant organisms, and after failure of DARE. They find that double DARE or repeat DARE sometimes can actually have worse outcomes over time. This is a question in the international consensus meeting: should operative treatment of different patients with systemic sepsis in the setting of PJI? This is all retrospective studies, and all studies recommended 2 stage exchange because you can take out the offending apparatus or implant that's causing the infection and get rid of their sepsis, which is key because that obviously leads to high mortality. And this is the finding here: 79% were in agreement here, because the idea is if you remove the components, you remove the bioburden, and that way patients can actually recover from their sepsis. There are limitations to 2 stage exchange arthroplasty, which we're all well familiar with. There is increased morbidity and mortality when you have to go through 2 different stages. And again, the multiple operations, it's hard to go under multiple anesthesia. It's hard to cut the incision multiple times. It's not good for the skin, poor for wound healing. There's also impaired mobility and contracture issues between operations. That's where articulating spacers became more popular with time, because it allows the joint to move. So you have less soft tissue contractures that way. Longer hospitalizations for 2 stage in total. It's expensive. And the really big thing is the caregiver burden. When a patient has a spacer in, and this is before we started using the, metal and poly or the Prostalax spacers, is that patients couldn't ambulate well. So you needed a caregiver to watch out for you for 3 months or longer if you were between stages. So the true success rate of two-stage exchange arthroplasty, defined as no infection, no mechanical failure, and no reoperation, is as low as 65%. So while some reports say 100%, it's more likely 65% depending on what people define as success. So not to increase success per se, but to decrease the morbidity associated with surgery, more and more people started doing one-stage exchange arthroplasty. And this started in Europe in the endo clinic. And it's ideally a single procedure with complete removal of the infected parts, which is the same as a two-stage. But the idea is after debridement, you close the wound, you change scrubs, you can have new instruments, you can re-prep, re-drape. And in some places, they even go to a totally different operating room and they wheel the patient to a different room that's totally clean. And then you re-implant. And it's all done during the same stage, hence one stage exchange arthroplasty. It is not yet a gold standard in the United States. And what are the indications? This is from the International Consensus meeting, where the host has to be basically pretty healthy, not immunocompromised, not septic, has minimal bone loss, and it can actually close the soft tissue. You have a known microbiology, meaning you know the organism that you need to treat, and you know the sensitivity, so you know what to kill it with. The ones listed below are relative contraindications to one stage. You can still do a one stage, but it depends how much you want to push the envelope. So this is a study that was published out of JOA that asked, is the preoperative identification of the infecting organism essential before single stage revision hip arthroplasty for infection? And the answer, as you can see here on the right-hand side, the p-values were not different with regards to recurrence of infection, re-revision, all-cause revisions, and septic re-revisions, meaning you didn't necessarily need to identify the organism. It's ideal to know what organisms there, obviously, for treatment, but there's actually questioning the original criteria, saying maybe the idea of knowing what organisms there might actually be a relative contraindication. Here too is looking at patients who got reinfection with the new bacteria after single stage exchange. This is specifically for Enterococcus. So Enterococcus is a tough bug to kick. This is only in 40 patients, of which they had 45% polymicrobial infections, 55% revisions, and 68% for PJI. And in those who recurred their PJI, 60% were new organisms and only 10% had Enterococci again. So we have to be careful that if you do one stage in these patients, they can get infected again. So be careful and really think about how you implant this patient. Some people advocate for fully cemented stems every single time you put in a revision implant. Some might say, well, if I put a fully revised stem in there, then taking it out might be more difficult if I get a multi-drug resistant organism. So things to think about as we take care of these patients multiple times. And again, how do you perform a one-stage exchange? Take out everything, including cement, do a thorough debridement, and we're talking tumor surgery, copious irrigation. Thorsten already covered this in his talk very well. Loose closure of the wound over sterile, betadine soaked sponges, close the room completely. Again, you can do it in a new room, change staff scrubs, open new instruments, basically open up like you have a brand new room, re-prep the surgical site, take out the stitches, take out the sponges, don't forget counting the sponges, place new implants with antibiotic impregnated cement, not high dose, but the normal dose that comes in the package, and then closure, and then plus or minus a incisional wound vac, as people like to use. So the recommended advantage is that it shows that during the international consensus meeting that the advantages include the decrease in morbidity mortality, earlier functional return, decrease in healthcare and global economic costs, and an increase in health-related quality adjusted life years. So all benefit, but we have to be sure that the reinfection rate is not worse. Again, it's beneficial because they have similar infection control. They do have relatively low reinfection rates, and success rates, again, range across the board. And we say there's better things overall and possibly less antibiotics for our patients, which can be good from an antibiotic stewardship standpoint. And you can see this is the endo clinic I was talking about. This is actually 10-year hip results. And they found that over time, while not ideal, the infection-free survival rate was actually pretty high. So the limits are one stage is that there's a lack of large multi-site studies, but luckily we have people on this call that are participating in the 1 versus 2 stage exchange arthroplasty study run by Dr. Faring down in North Carolina. There might be an increased risk of reinfection with immediate reimplantation of an implant that's metal. You may remove too much soft tissue. So for an example, EndoClinic first initially said everything has to go when you're doing the thorough debridement, including the MCL and the LCL, and then limited local antibiotic delivery as opposed to a spacer that's in there for at least 6 weeks. So in conclusion, they both provide good treatment for infection. Patient selection is key. How you do the procedure is more important than anything else. Antibiotics used, you want to be specific to the organism if possible, or the standard organism or the standard organisms at your hospital. And it's nice that we have ongoing prospective randomized controlled trials. We have 2 of them ongoing on 1 versus 2 stage, and we'll definitely want to see what the results show there. Thank you very much. So once I do a 1 versus 2 stage, I have to go back in and reimplant everything. I'm going to have Dr. Lewallen talk about the current use of porous metaphyseal cones in revision total knees. And I have to say, during a traveling fellowship, I got to witness him put in the first round of a certain type of cone. So it's been a pleasure to watch that. Dr. Lewallen?
Thanks very much. It's a real pleasure to be here. I've been asked to talk about placement of porous tantalum cones, and I'm going to try to cover current usage. These are my disclosures. They're pertinent to this presentation, some of the implants we've helped design. So bone defects can range from minor defects that hardly affect the implant usage to nearly non-reconstructable. And as we get into more major defects, in the past, structural grafts were used, and more recently, we've been able to use metaphyseal cones for structural support of the implant, at least initially. The original concept as we developed these devices and extended really our work from the hip to the knee was to think of prosthetic structural allograft, trying to come up with shapes that would fill large voids and provide support so we could use off-the-shelf revision components after reestablishing a tibial platform. This shows how it works. Tibia on the top, femur on the bottom. You can see the trial implants with the yellow blocks or augments we're accustomed to using for reestablishing the tibia and then balancing the knee in both the flexion and extension gaps to try to reconstruct the joint. Here's a case from a few years ago. Polywear used to be an epidemic. A lot of the stimulus for this work came out of cases like this with huge defects, and the large cones would be placed with then particulate graft if you had any residual gaps between the cone, but trying to maximize cone contact on host bone. And this allowed the use of relatively short stems along with cement under the implants on the distal femur, proximal tibia to hold things still while the bone grows in. And here's the strategy on the femoral side. You see a large femoral cone placed, some cancellous bone, and then a bone graft substitute placed, and then cemented stems. You can use cementless stems as well, as long as they're diaphyseal engaging and provide enough support to hold the interface still while the bone grows into the cone. We've had a chance to report our results and invite you to look those up. First, the tibial side, we had those implants sooner. Excellent results in what were our worst defects with very high rates of survivorship, despite really being the more extreme bone loss cases. Similar story on the femur with surprisingly good survivorship actually at 5 years and beyond. Failures for sure, but relatively few for the kinds of defects taken care of. And as we went along, we came to understand that maybe what was going on here was this hybrid fixation of an individual component, kind of a new way of thinking of the fixation for these devices for people who had grown up cementing everything, but trying to get this bone ingrowth for durable long-term fixation. So that anything that holds things still to allow bone ingrowth is good, and anything that allows things to move around is bad. But it prompted development of smaller cones for more routine use in cases where, frankly, in the past, we wouldn't really have thought of using much, but maybe a small little block augment to make it last longer. Because as we were doing these big cases, we had our own folks coming back from early revision surgeries we had done with 5, 6, 7 years out, loosening of implants where we thought we had almost primary-like bone. So I think when these folks have damaged bone, the potential for cement interdigitation is reduced, and trying to get some kind of biologic fixation can make things more durable, again, as we have learned at the hip. So this just shows a subsequent smaller series of cones with some rasps. Not a good thing to do if you have a thin shell left. If you've got cancellous bone you can remove, and you can use the rasp to prepare with first the trial and then the real implant impacted into place. Reestablishing the metaphysis, and you can see the bone in place on the tibial side. Similar strategy on the femur now. Again, we don't need this for structural support. Look at those condyles, they're pretty good. This is really a fixation strategy for that central metaphyseal diaphyseal junction, trying to improve loosening rates over the longer term. And then bringing the real implant in after you've done the trialing, decided on your buildups, and then putting the cone into place. They're impactors for these cones, but I think it's actually safer to use the trials as the final impactor. It avoids over impaction. These are wedge-shaped devices, and if you pound them in far enough, you can split that bone like you would split a log. So you have to be careful you don't over impact beyond the level of the preparation for the rasp. But this shows the kind of metaphyseal fixation that then is a pathway to more durable long-term fixation. As I think everyone knows, there are a number of systems available now from a variety of manufacturers. This just shows a ream system for a 3D printed titanium implant. Matt Abdel provided these slides from one of his cases. And similar strategy on the femoral side, central reaming, and then an offset reamer when you have the need for kind of a double bubble configuration or more elliptical bone preparation. I wanted to highlight this technique we just published in 2020 on kind of extended use of cones. You know, we're seeing more and more difficult cases, people with damage in the diaphysis from either prior cemented or cementless stems, and now the diaphyseal part's damaged and not very supportive. And this is impaction grafting of the canal. And yes, you can tell it's a bunch of hip surgeons doing knee stuff, because it's very much like our experience with impaction grafting in the femur of a total hip. But this kind of impaction of a damaged diaphysis then allows you to cement into that cancellous bone and provide restoration of bone and really excellent stable fixation. Remember, it only has to hold still for a few months while the bone grows into the cone. You're going to win or lose during those initial few months. We had 35 of these cases in the report. It was only 1% of the revision knees we did during the time frame. So we weren't doing this all the time, but I must say we're doing it more because our initial results were really excellent in a difficult crowd. So I'm sure we will have failures, but the initial cohort, excellent results. There are also sleeves that are available for use in some systems, prepared and then introduced with the implant as one final construct. Another strategy, again, for maybe some types of defects, intermediate in size, they can work really well with good reported results. So how do you put this all together? You know, I think this makes sense. It's sort of a consensus from our group that you don't need these all the time. You can use standard techniques with people with minimal defects. As you get into the moderate size defects, we're routinely using some type of metaphyseal porous fixation, really to improve performance, even if it's not needed for structural support. And then the large cones come into play when you start, you know, really losing segmental deficiencies, major defects that don't provide rotational stability to your implant. Ferris Haddad has recently published sort of a white paper more than a series, an opinion or discussion paper about thinking about revisions with 3 zones, pararticular, metaphyseal, and diaphyseal. And I think, you know, this puts words to some of the concepts, and that's helpful. It makes people, I think gives people easier time understanding what we're talking about. We think that zone 2, the metaphyseal fixation, though, is the key and really the foundation for the reconstruction moving forward. Thanks very much.
Thanks so much for a great presentation. Really appreciate it. We're moving on to Dr. Brawley now, and he's going to talk to us about distal femoral replacements for periprosthetic fractures. Please take it away.
All right. So distal femur replacements are DFRs. Houston Brawley from UT Ortho. Antonia, you did a great job in pronouncing my name. Everybody says Braley, so it's Brawley, so that's awesome. Sorry about my background. I got a daughter about to be born here in another month and a half, and everything's pink, so it doesn't, my face doesn't show up here well, but this is the only room I have available at this time. All right, so DFRs in the Mayo Registry, primary TKA is about 2.3%. If you revision TKAs, it's about double that. If you look at overall periprosthetics for total knees, when we talk about distal femur replacements for this, it's a majority of them, 0.3 to 2.5, probably more than 2.5. You know, when you see, every once in a while, you'll see a periprosthetic tibia and also a patella fracture, which I've treated several of those, but kind of your workhorse or the majority you're going to see is the distal femur replacement. Now, the complications, keep in mind, are very high. A lot of this is also soft tissue management, and some of this might also be influenced by, well, infection, and a lot of that you can't control. It's hard to really get a workup, and what are you going to do to really find cultures that your patient's been sitting around? So it's a high complication rate. I haven't seen it that high in my practice. I've probably done about 60 DFRs in the last 3 years. We just have a very high rate of volume in our facility, but sure enough, we had some complications. Risk of fractures, notching, you know, there's controversy about that. We do know that in at least some lab studies that the torsional strength is decreased. I've seen a lot of notches. I've done a few myself. I haven't seen any problems, but it definitely can weaken the bone. So I try to avoid if possible. Intercondylar box cuts. I think this is the one that I see with a big box for a small female. This can cause some issues. And if you don't clean out the box either deep enough or wide enough, when you're putting in your trial or even your final implant, you might have a problem there. And that will split the condyles, obviously. Some risk factors, implant loosening, osteolysis, these are all common knowledge. Notching above the TKA, controversial. About patient factors, you will see, I think, more in rheumatoids, chronic steroid use, your renal patients too. Osteoporosis, those all kind of go hand in hand in female, and of course, increasing age. And we do know that periprosthetics are becoming one of the more and more common causes of revision over the last several years. There's different classifications. I don't think these are as particularly important as the Vancouver classification when you start talking about the proximal femur. But again, it is at least good classification, at least for research purposes. But the majority we're seeing is a 2 or 3 below, where we're going to have some loose implants, or is there enough bone quality? So there's the different options to treat here. Obviously, there's non-operative treatment, there's open reduction internal fixation, revision TKA, and distal femur replacement. And remember, I think the big thing is the clinical picture is just as important as the x-rays. This is a little bit story. This is probably my only non-op DF or non-op periprosthetic fracture I treated. This happened about a year ago. It was this lady, I was going to my clinic, I was running late, ran into the lobby, was going to take the stairs, and all of a sudden the elevator was open and closing on this lady's feet. They were hanging out. And another lady says, "Is there a doctor that can help us?" I'm like, oh my gosh, she just saw me. So I ran over there, and there was a lady, almost completely pale white, laying down flat on the ground. She was barely breathing. I got down, and then she stopped breathing. I was feeling pulses. Then she lost pulses. And still this elevator is like closing on her. It's just like out of a movie. So I started chest compressions. All of a sudden a cardiologist showed up and started feeling for pulses. And after about a minute or two, I got pulses back. And I said, "Man, I got to go. You're really a heart guy. Can I leave you here? I'm being late for clinic." I ran to clinic. And I'm not kidding you. An hour and a half later, I got called by the ER right next door. They picked her up from the ambulance. And they said, "Hey, Dr. Brawley, we got this patient. Apparently she coded. Some guy did chest compressions. Anyway, she's got a periprosthetic distal femur replacement fracture." And I go, "Oh my God, goodness." And she had some minimal comminution, but she had to get angio and all that stuff. So I treated her non-operatively, and she did well. So there are those exceptions. So why DFRs? You got to get them up and moving. They're older patients. If it was my grandmother at 80 or above, I would err on replacement rather than ORIF. And why is that? I think they get them up and moving fast. I think it's similar to having your kind of like a hip fracture. Well, we're not going to treat it non-operatively, even though there might be some retroversion. We're going to get up and we're replaced. And I think there's better results with that. And why DFRs? Well, it's really, for me, it's what I'm sitting. We're the biggest level trauma center in the world. No big deal. But we do see a few of these, and they do well. Now, my long-term results, I've only been 3 years. That may change, but intermittently, I mean, you know, in my practice, they've done pretty well. Osteoporosis, sure, it still heals, but is ORIF really worth it? Yes, if you can. Mortality rate, is it higher with ORIF versus a distal femur replacement? I don't know if we know the answer to that, but I think getting them up and moving, less chance of going to skilled nursing and having a complication such as a breakdown of your ORIF or having to revise this. I think it really is kind of, well, can we do a 1-stage or do we need to do a 2-stage? And DFRs, I think 80 in the literature is pretty consistent. I think that's a pretty good cutoff, but really it comes up to the person. In reality, there is no cutoff. If it's loose and there's no hueso, it's no bueno, so you need to replace it. So I do either press fit or cement. I've really steered away from the press fits. I've had the periprosthetic fracture, placing the press fits later at later times. I use the sleeves. I like that for revisions, as Dr. Lewallen had talked about, but sometimes for a periprosthetic female, not a good idea. So I do tend to cement, and they have done them reasonably well. So in case of the bilaterals, every year I've had bilateral distal femur replacements. So in the last 3 years, bilaterals, and I've done these in stage. And this is a patient, 81-year-old female, RA, like we talked about, with wrist fractures, osteoporosis, fell hyperflexion bilaterally. She walks with a walker at baseline. I did these staged at 3 days apart. The last one I did was a couple months ago. I did them actually one day, start with, and then the next day I came back because she was a younger patient with a lot of comminution. But they've got up, walked. This lady's been a small little stint at the skilled nursing facility, but she's doing well. Again, good range of motion. If anything about DFRs, they always have good range of motion. It's a salvage operation. It's really patient dependent. It's one and done, less chance of failure, at least early on. There is loosening. We do know that, especially with the hinge. But with an older patient, I do believe to take the whole clinical picture, in my opinion, to get them up and moving is important. Thank you.
Great, thanks so much. That was a good presentation. We're a little bit over, but I'm going to do a little bit of discussion time. So I think a question that we all have burning for you, Dr. Lewallen, is when do you choose cone versus sleeves, and which cone system would you use?
Well, so I think there's ample evidence to suggest that really the principles and the strategy of trying to achieve kind of porous ingrowth in one area and adequate cement fixation and stabilization in the diaphysis, if done well, will work. And you can do that with cemented stems of modest length, or you can do it with well-positioned diaphyseal stems. They can also all fail if you don't do a good job with your technical procedure. And I think actually it's probably less important the specific cone sleeve material than how you use them. There are cases of great success with each of the systems in the hands of people that are comfortable using them and experienced with them. And we continue to see cases that fall right out when not put in, kind of follow on the rules. And so I think using a system you're familiar with and using it well is the most important thing. Having said that, as I said in the talk, as the defects get bigger and bigger, you need something bigger to fill it up. And that's where the big cones come in. And those are interchangeable with any system. So you can use whatever manufacturer's implant you want, and switch to a rotating hinge. So it gives you a lot of flexibility. The smaller you go, the more these systems become implant specific. And sleeves, for example, really are one system specific. You have to use it with them only. And there are other manufacturers coming out with sleeves, but they'll have the same limitations. They'll only work with the particular system in question. And I think best for kind of the mid zone of the defects, not the crazy stuff.
Great, thanks. I appreciate it. And for the complex primary needs, Dr. Hocker, what do you do in terms of technology? I know you mentioned navigation, but how do you choose what technology to use? What do you consider when undergoing these complex cases?
So for me, the default is actually preoperative CT customized blocks just for speed. Navigation is helpful in the case that I did with the post-traumatic, because there's so much hardware there that you can't get an accurate scan, so it throws it off. But most of the time, if I'm in these deformity situations, it's really, for me, it's the femur. The tibia, I still do extra medullary alignment, so I can usually get a pretty accurate alignment based on the bimalleolar axis. So for me, the workhorse is PSI, but if I don't want to disturb existing hardware and that's going to obscure my scan for a customized femoral block, then I'll go with navigation.
Sounds good. Thanks. I appreciate it. And Dr. Brawley, I hear you when it comes to the distal femoral placements and cemented stems. What happens though when a patient has to go back and they're infected and you have to get those cemented stems out? You know, does that change your algorithm for cemented versus hybrid cemented stems?
That's a good question, and that's why I think I dabbled in the non-cemented stems for a while. But when you really have like parchment paper for what's left, you know, in like a shaft, and they're the little old ladies, and you just take a reamer to really kind of get a little touch and start splitting. That's when I just kind of said, I think I just cement and get out of here. On the bigger males, when there is bone, it's more of a traumatic rather than a fall. I think it definitely has a better option for the press fit. Thankfully, I've had only one infection in all my distal femur replacements. I can't believe it. Okay, but I've had one, and that person was actually an open distal femur fracture. It underwent an IND, and she had kidney failure and diabetes that we eventually let all her wound tissue heal. She had to have a flap, like just for a regular knee. They treated it non-operatively and came to me. So she might have still had infection, had to have plastic surgery to do the exposure. But that is always my worry. And when she did get infected, we noticed it early, and I did the whole Seyler treatment, and we got away with it. But it's a great question.
Great, thanks everyone. And if there are questions out there, which would be great, and we'll be hopefully address some of the hip ones. Actually, as we're switching over, Dr. Brawley, there's a question specifically for you. When people are coming in with distal femur paraprosthetic fractures, are you routinely getting ESR CRP and sending fluid prior to doing a DFR to make sure they don't have pre-existing smoldering PJI?
Yeah, everybody gets a ESR CRP, a prolactin, a prealbumin. I'm doing everything in the world to try and prove that they had an infection before, to be honest with you. If I can get an aspiration, I will. Sometimes it's a very bloody aspiration with the involvement of very distal, but everybody gets attempted to be aspirated. Do we have time to send that for a synovusure? Sometimes synovusure seems faster than our hospital's returns, but I am taking fluid. I am sending specimens, and multiple specimens, at least 5. But yes, it is a workup. If there is evidence of, if you have a pre-op films and you do see signs of infection, I would have a very low threshold. You can send your frozens, but again, you just had a lot of trauma. That might throw it off. But I will send frozens, and if there is any risk, I will do like a potential staged or at least a cement rod to hold them out and come back.
Great, thanks a lot. We'll talk about people taking care of revisions. One of my colleagues across the pond, Dr. Melnic, is going to kick us off with the first talk, specifically talking about acetabular bone loss.
Great, thanks, Antonia. So disclosures, none that are pertinent for this. So overview, as we all know, a revision total hip surgery is quite a complex procedure. It's further complicated when you have associated acetabular bone loss. So the etiologies of the bone loss is important to understand. And when you're removing components, you want to make sure that you're not the one that's causing any excessive bone loss throughout the case. That's going to make it more challenging. An in-depth understanding of your bone loss management is critical. Its versatility then is afforded to you in the operating room. Once you take the components out, you may have to reclassify. So it's important to understand what your different treatment options are. And then this may be associated with a discontinuity, which is important to understand early on in the treatment. So the Poprosky acetabular bone loss classification is the most commonly used one. It allows for both identification and then subsequently treatment options. There's the gross classification as well as the AOS classification. The preferred treatment classifications for me would be the Poprosky classification. So it's based off of 4 radiographic criteria on the AP pelvis radiograph. It talks about superior migration of the hip center, the degree of osteolysis in the ischium, and then subsequently also in the teardrop, and then the position of your component relative to Kohler's line. So the classification system summary here is image down here by Dr. Poprosky. But basically your type 1 acetabulum is a hemispherical acetabulum. Your type 2, you have intact columns, but a distorted acetabulum. And then type 3, your columns are not supported and the acetabulum is also distorted. And there's your anterior superior column and your posterior inferior column. So in your type 1 Poprosky classification, both your anterior superior and posterior inferior columns are intact. And then your acetabulum remains hemispherical. And we'll go into a little bit of the treatment options a little bit later on, but that affords you the opportunity to just use a hemispherical shell. Your type 2 are then split up into type 2A, B, and C. So in 2A, you have anterior superior bone loss. In your 2B, you have lateralization of the hip center, as well as superior bone loss. And then your type 2C, you have both medialization of the hip center and your ischial-ilio line is violated. And it's great Dr. Lewallen is joining us here tonight. I remember when I was a resident and a fellow sitting in the audience, listening to some of his talks, talking at the academies about really achieving inferior fixation. And then when I was a fellow with Dr. Poprosky, talked about that as well. So that's what I've really tried to take as a key point for some of these fixation, these complex cases, really trying to get ischial screws as well as superior pubic ramus screws, and then turning your attention to your superior screws. And then you have your 3A and 3B acetabulums. So your 3As are thought of as your up and out defects, and then your 3B are your up and in defects, where Kohler's line is violated, and you typically get about greater than 60% compromise of your host bone. So pelvic discontinuity is the separation between the superior and inferior hemipelvis. This can either be acute, as you see here on the right images there, or chronic. In the acute setting, you need an open reduction internal fixation of your posterior column fracture, and then an acetabular component revision. And then the chronic ones are thought of as a fibrous non-union with numerous treatment options, which we'll talk about here in a second. But so in your Poprosky type 1 and type 2 defects, just a quick review of the literature here. Basically 90% survivorship with aseptic loosening as an endpoint when you're using the uncemented hemispherical shells, plus or minus bone grafting. And then you get into type 3 defects, and there's numerous different options out there. 3 of the most popular would be your cup cage construct, your custom triflange, or the school of thought that I am under is the distraction technique, if a chronic discontinuity is there, but just using jumbo porous metal cup and augments, as seen in some of the examples here. So in summary, just keeping to the 10 slide minimum or the restrictions, this is just basically severe bone loss management is extremely challenging. Your success is predicated on that stable construct that allows ingrowth. And once again, can't stress enough, especially in the beginning when I started taking care of these and had a run of chronic discontinuities when I started at MGH, you're quite nervous in your first couple of cases and you're trying to get screws anywhere. But I think the incorrect thing to do is try to just get superior fixation and then turn your attention to the inferior fixation, because a lot of times your cup ends up not being in the correct position. So now what I end up doing is I start with my inferior screws, try to understand the ischial anatomy, get my ischial screws in, and that cup often ends up being vertical and pretty much neutral to allow you to get those screws as well as the screw down the superior pubic ramus, and then turn my attention to the superior dome screws. And then a lot of times, as the cases are shown here, there's different constructs that get cemented in, either a liner or another cup that allows for a dual mobility option. But then that is then cemented into the appropriate anteversion as well as inclination to give you a stable construct. And then once again, basically proper identification of the defect while you're operating is important as well.
Fantastic. Thank you very much, Chris, for sharing on tips and tricks that I'm sure you use in the operating room often. We're going to go back to Dr. Lewallen, who's going to talk to us about systemic symptoms of metallosis after total hip replacements. What, when, how, and why? Take it away.
Thanks very much. There we go. Okay. I'm going to try to go quickly through this in the interest of time and no disclosures of pertinence. First, metal comes from a variety of causes and it's complicated. Patient factors, implant, material, performance factors, loosening, malposition, bearing couples, and wear that may occur between those. And so it's hard to make blanket statements about where this stuff comes from, but suffice it to say, with the work we do, there's real risk of developing metal debris from wear or corrosion products. And this all sort of hit the fan 10 years ago with the metal on metal problem. And initially this was a focus on wear and pictures like this. And then newspaper articles like this with regulatory bodies taking action against orthopedic implants and manufacturers and their ability to sell these things to the public. And right about the same time, an article showed up read by a guy named Steve Tower from Alaska about 2 cases of neurologic and cardiac manifestations of metal total hips. What wasn't made clear to the reviewers of this article is that one of the index cases was one of Dr. Tower's patients, but the other one was Dr. Tower himself. So he wrote himself up and published it in the JBGS. I don't know if anyone else has pulled that off. But the concern related to cognition and also changes in cardiac echoes and concerns about even heart function and heart failure. I think that corrosion is something we're all attuned to now, I think, from the last few years, because it's sort of also hit the fan with regard to some of the modular connections, trunnionitis from the heads, and also some of the double modular necks. And the local effects are one thing, and they've been the focus of some of the initial reports going back to the 90s on modular connections, and then the Rush group talking about adverse local tissue reaction due to these tapered connections. This kind of thing, which can be quite dramatic after a few years in place. But other variety of modular connections, which have kind of exploded across hip arthroplasty and then in some cases beaten a retreat. But we continue to see new modular connections all the time. Patients like this who come in 15 months after surgery, told there was nothing wrong with her hip and go see the spine doctors, and she's having trouble walking from a femoral nerve palsy. Here are her blood levels for cobalt, not all that alarming, but here's the axial studies showing this big mass on the front of her hip. This is the corrosion at the base of the double modular neck. That was the only source. She had a cross-linked poly and ceramic articulation. Here's her femoral nerve after decompression, and 2.5 years later, she's got a hip that doesn't hurt and is disabled by her persistent femoral nerve palsy. So local troubles can be bad. We all know that, but what about systemic stuff? And what's the risk? You ever wondered what's going on in the joint with some of these implants when you get local changes? Well, here's the synovial fluid levels on that lady. So she had cobalt in her blood 5.1, but it was over 1,400 parts per billion in her synovial fluid. A huge repository of metal debris we often don't get out. We did a study of a bunch of metallosis type revisions and then standard revisions and compared them. And look at the difference in the metal levels in the synovial fluid, especially cobalt, which is the real killer in the metal type cases. And by different types of failed metal implants, you can see where metal on metal is, metal total hip, much worse than resurfacing to explain the dichotomy and results of those two similar articulations. It's not wear, it's the corrosion. And then the double modular neck's way behind. And then this question, in a crowd where it's in live, I usually ask how many people in the crowd have ever seen anybody with systemic manifestations of cobalt. There's hardly ever anybody there, but of course, are we looking? Do we know what to look for? It turns out you can have a wide variety of things that affect patients, changes in their immune system, kidney problems, cardiac, hearing, deafness. But this sounds like a lot of my patients pre-op, let alone post-op. And how do you know what's going on that's just part of the aging process and what's from potentially what we're doing to them with our procedures? Well, it turns out you can kill people with too much cobalt. And this was first shown by the Canadians, thanks to the French Canadians and beer drinking. There was a brew up there that had the foam stabilized with cobalt, and a bunch of the locals who really liked this one particular brand ended up with heart failure, and 20 out of 50 died. If you fast forward 2014, patient coming into Mayo Clinics, consulted, one of my partners was consulted by cardiology. He comes in heart failure. She's on ECMO, and they note that she has bilateral metal total hips that were put in 5 and 6 years before. They knew that she had elevated cobalt, but they were just following it because she didn't have any minor symptoms. That's the recommendations, right? So this lady ended up with bilateral revisions done emergently, heroically. They were able to pull her through the procedure, trying to get her cobalt down from 199. And her heart biopsy showed cobalt cardiomyopathy, and not a great deal of wear, not real dramatic. And unfortunately, she died 1 week post-op from a bleed into her head from all the anticoagulation for the pump that she needed to be on for her heart. So you go, well, you know, is that a big deal? Here's a patient of mine from 2017, 59-year-old attorney, 6 years post-op, sees her home local orthopedist with this exploded ceramic on ceramic after squeaking for a few years. No pain in her hip ever, but within months she started developing hearing loss, visual acuity changes, hypothyroidism, sinus tachycardia. Saw good people in a medium-sized city. They had no idea what was wrong with her. Her daughter watched a movie on Netflix called The Bleeding Edge and said, I think that's my mom, because of all of her symptoms from metallosis. And her cobalt was over 1,000. When I met her 17 months post-op, her husband would have to repeat the questions I asked her and yell in her ear, he wants to know if it hurts. And she couldn't see me. So we ended up revising this and taking all this sludge out. Okay? Washed out, cleaned out, replaced, ceramic on poly, and over time her levels came down. And I can tell you in a year, she can talk to me on the phone now with hearing aids. She can read a book but still has central vision loss, and she made it, but almost not. She had a near arrest post-op from tachycardia and congestive heart failure. So she had cardiac changes as well. And this is all cobalt related. This has been reported in the literature. So don't ever, ever, ever put a chrome cobalt head in someone with fractured ceramic. Some people have gotten away with it because they can turn into cases like this. And the literature has a bunch of case reports, including deaths with embedded ceramic debris. You just can't get all the stuff out. But don't ever do that. In summary, you know, what is the problem? Mostly local, but distant problems possible. When? It's years post-op, but sometimes only a couple if you have something like fractured ceramic. It's both wear and corrosion. And the why of it is the materials, the cobalt, the designs, the high demands, and failed follow-up and awareness. That's on us. We need to follow people with at-risk implants and know what those are and try to avoid unnecessary use of some of these metals in high-risk situations. Thanks very much.
All right. Without further ado, thank you very much, Dr. Lewallen. And last but absolutely not least at all is Dr. Bradbury. He's going to speak to us, and he's going to talk about instability after revision total hip arthroplasty, anterior versus posterior, which is obviously still a hot topic of debate when it comes to hip approaches. Dr. Bradbury?
Antonia, thank you, and happy holidays to everybody. And for those of you who have the grit to stick around for the last talk, hopefully we can give you some information, and excited to share what we're doing. So going to talk a little bit about instability after revision total hip arthroplasty, and some about the influence of the approach used. Disclosures are not pertinent to to this talk. So First question is this a big problem? If you do revision hip arthroplasty, unfortunately, this is part of the game, right? This is a known complication. It exists in the primary world, but it's much more common in the revision world. And the literature would tell us that this is one of the biggest problems we have after hip replacement surgery. This is a Bozic study from 2009, another Bozic study from 2015, and a Guam study from 2017, all of which report that the most common reason for revision surgery, most common indication is instability. It's about 20% of all revision cases. So it's a big deal. Not only is it a big deal, but it's a problem that's hard to treat. And this is from Dr. Lewallen and Dr. Sierra's group at Mayo, looking at instability after revision hip arthroplasty over a 15-year period. Those people that require repeat revision for instability will redislocate. That's not insignificant. So it's a tough problem to treat. And it's also an expensive problem. Every time you go back to the operating room for revision hip arthroplasty, this is another Kevin Bozic study, the cost is not nominal, $55,000 per episode. So it's a pretty big deal. So I think orthopedic surgeons and the community that we work in are an innovative group of people. And over the past 2 decades, we've tried to come up with better ways to manufacture implants to reduce the incidence of instability. And I would argue that most innovations that have come about in hip arthroplasty have all surrounded around, to some extent, instability. The first thing that Dr. Lewallen just discussed was the metal large diameter non-modular metal on metal bearing. This was a popular design when I was finishing fellowship and starting my practice. In fact, the first 3 hips I did were this design because I thought it was going to be superior. And unfortunately, that evolved into a big problem. We just heard a lot about adverse local tissue reaction. This is an example of the effusion that egressed from this hip on arthrotomy. The next customer in line was the modular femoral neck. Unfortunately, this was a cobalt chrome and titanium couple that was a utter and complete disaster that harmed a lot of patients. But again, the innovation was based on the idea that you could recreate the patient's anatomy and hopefully improve their motion before impingement with this particular design. It ended up being a disaster. And then the latest kid on the block has had a lot more success. And I think a lot of us are starting to utilize dual mobility technology, especially in situations where there's abnormal spinopelvic kinematics or deficiencies of abductors. But even that technology is not without risks. This is an example of intraprosthetic dissociation in a patient that I took care of. So there's a snake under every bush. So when we talk about the keys to success in revision hip arthroplasty, I would first start by saying the approach is probably not the most important part. It's probably important to follow these 4 ideas when you're talking about revising hips. Number 1 is to identify the cause for which you're revising. And in cases of instability, we'll talk about this a little bit. We know a fair amount about that, and just taking somebody back to the operating room to see what things look like without trying to identify a cause prior to surgery is probably not a good idea. Number 2 is that you have to know the components. They play a big role in the techniques you use to pull things off with revision surgery. Number 3 is a safe and wide surgical exposure. We do a lot of harm to people trying to do things that we don't do correctly because our surgical exposure isn't adequate. And yes, you can make the argument that big surgical exposures cause some morbidity, but I would argue that the morbidity from having inadequate access and causing a problem because of that is probably a much bigger problem. We'll talk a little bit about anterior versus posterior in that regard. And then the 4th thing is bring the right tools, right? You got to have the right equipment to get these things done safely. And I would also argue that 90% of the work done prior to revision hip arthroplasty is done before surgery, not in the operating room. If you do your work beforehand, the case is actually a ton of fun and will go much more efficiently. So why do hips become unstable? This is Craig Delavalle's group at Rush that published a study about 8 years ago, and they looked at about 70 unstable total hip arthroplasties. They defined instability as someone that had had 3 or more dislocations, and they looked at the reasons why. And after surgery, they categorized folks into 5 categories. The most common was component malposition, right? And I would argue that in 2020, we're starting to learn how important it is to place the components in the correct orientation in terms of producing a stable joint. And I would also argue that some sort of navigation will likely become standard of care in the near future because I think it makes a difference. Number 2 is abductor insufficiency. That's a big problem. There's no great solution for that, but it's a big reason for instability. Number 3 is impingement. That's directly correlative to component malposition, but it can also involve extra articular impingement, i.e. trochanter on ilium or trochanter on ischium, leveraging the hip out of joint. And they added 2 other categories, wear-generated instability and an unknown category. And I would beg to differ that wear-generated instability with highly cross-linked polyethylene will likely, hopefully, become a thing of the past, and that number 4 and number 5 are going to be replaced by abnormal spinopelvic kinematics. So the etiology of instability will evolve over time, but I think in a lot of cases, in most cases, you should be able to identify why a hip is unstable. I brought up why knowing the components are important. These are 3 stems that I would argue that you probably would not be able to get out from the top. You'll probably need an osteotomy to get these out. The one on the left is a fully HA-coated stem, and although it's the quote-unquote Karai potted plant, it's still grown in distally, and it can be a bear to get out if you don't do the right exposure. The Mallory head stem in the middle, less commonly seen, but is grit blasted all the way down to the tip. It can be very difficult to get out. And then the grandfather of them all, the fully porous coated AML, which will take 2 hours of your time getting out. But if you do the right technique, you can get it out without hurting the patient and provide the patient with a good outcome. So wide exposure is important, right? So a lot of us use a posterior approach for our revision hips. It is expansile. It's very utilitarian. And if you can't get something out from the top on the femur side, you can easily transition to a traditional ETO. A lot of us have started doing more work with the anterior approach and doing a lot of revision work through the front and becoming quote unquote braver with what we do. A lot of folks will say that the revision femur is more difficult, but as we have gained knowledge and learned that osteotomies are very possible, this approach is gaining acceptance, and a knowledge of the Wagner or transfemoral osteotomy allows really expansile exposure of the hip from the front of the joint. The toolbox is huge. This is fun. There's all sorts of gizmos you can buy to help get implants out. I would argue that 3 things will help you more than anything else. Number 1 is a high-speed pneumatic burr. With a round burr and a pencil tip, you can get around the majority of the proximal portion of most implants. And if it's a proximally coated implant, that is 90% of the work. There are a variety of osteotomes that have hit the market. There's actually a group here in Atlanta that's done a lot of work with this. I don't have any tie-ins with them, but they've developed special set of osteotomes that are designed to help you get around the implant and divide the bone-implant interface without fracturing the bone. The osteotome you see at the top of the screen with the little U-shaped hole in it is designed so that the neck of the implant will go through that hole, and you can drive that osteotome down the medial aspect of the stem, which is kind of otherwise blocked without that type of implant. And the one on the right is designed to get around the shoulder of the implant, and you can get almost any proximally coated implant out with these tools very readily without damaging the bone, right? So the goal, don't break the proximal femur, don't break the trochanter, take your time, do a good job. If you break it, you kind of lose the whole game. And then having a good extraction device after you've done all your work from the top is very helpful. So I would argue that most stems can be, regardless whether you're going from the front or the back, most femoral components that are proximally coated should come out in 20 minutes or less with 6 fairly straightforward steps. Number 1 is good surgical exposure and truly defining the interface between the bone and the implant. Number 2 is to clear the trochanter. You cannot pull a straight stem out of the femur if you've got overhanging medial trochanteric bone without breaking the trochanter. Clean that bone up. With most revision stems, you're going to take that bone anyway. Don't break the trochanter taking the stem out. The third step is to take a pencil tip burr and go 360 degrees around the proximal aspect of the implant. It is very safe to cut bone. It's not safe to try to divide a bone implant interface with an osteotome. And so leverage that technology fully, then progress to osteotomes, which are very helpful for dividing the implant interface farther down the line. Steinman pins can be a little bit helpful. You can get a Steinman pin to try to reach areas you couldn't get with other stuff, and then try to extract the stem with an axis-based extractor, i.e., if you have a stem that will accept the threads of an extraction device, that provides a ton more extraction force than a loop extractor, or even an extractor that binds or grabs the stem off of its intramedullary axis. It's amazing how much force you lose with that. Give it a whirl. If it doesn't happen, proceed with the osteotomy. Don't bang up the femur trying to get the implant out. This is an example of removing the medial aspect of the trochanter from the front with a pencil, or excuse me, with a round burr. This is also doable from the back. This is an example of a pencil tip burr from the back, dividing the bone implant interface of a corroded modular stem. And again, take your time, go 360, make sure you've done the complete division before you start passing osteotomes, because there's only so much room in there to work. This is another example from the front, taking a pencil tip burr to divide the interface. And finally, the osteotomes. This is that special set of osteotomes. There's a flat osteotome, a lateral osteotome, and finally the medial osteotome. And with a blade style stem, which occupies the majority of the market share these days, you can get these things out very quickly and very safely with a little bit of effort and a little bit of time. And then having an axis-based extractor will allow the implant to come out, usually, depending on how strong your fellow is, usually pretty quickly. Sometimes it hits the anesthetist, which is always a good time. So with this hip that's infected, you can get it out, go straight back in, and do a single stage exchange for a chronic PJI, and perhaps save the patient a lot of angst and morbidity with the traditional two-stage exchange. I will tell you, I still consider the single stage exchange rather experimental until Tom Fearing's data is fully elucidated. We're really relying on retrospective series, and although Ferris Haddad series is very compelling, there's a lot of things out there that we don't know. And so I tell people, you're a candidate to get a one-stage exchange if you will enroll in our study. If you don't enroll, you're going to get a two-stage exchange. And if you enroll, I'm going to flip a coin, and you've got a 50% chance of getting a single-stage exchange. Otherwise, you're getting a two-stage exchange. It's amazing how many times people will leave your clinic because they want the one-stage exchange. But again, we don't have the full data on it. So if you can't get the stem out from the top, do a controlled femoral osteotomy. From the anterior approach, that's the anterior wall osteotomy. From a posterior approach, that's the traditional ETO. Before you commit to the ETO, try the quote-unquote episiotomy. It always amazes me how many times this works. It's simple. You do a longitudinal osteotomy from the top part of the femur all the way down past the ingrowth surface, put an osteotome into the osteotomy site, twist the osteotomy to lever the bone open, and then try to extract the stem again. There's something about the hook stresses that releases some of the pressure on the stem, and oftentimes you'll be able to get it out without a problem. If you're going from the back, do a quality extended troch osteotomy. The bigger your fragment, the less it's going to fragment. Take care leveraging that fragment off. Oftentimes you'll fragment that fragment. The bigger the piece, the better it is. And there's an example of a infected hip that got a two-stage exchange with a temporary implant on the right, with an ETO that healed very, very readily. At reimplantation, the trochanter is healed and accepts a standard implant. The anterior wall osteotomy, we're gaining experience with this. This is very doable. Obviously, the idea of getting to the femur from the front is a little bit daunting, but the basic gist is you extend the incision distally. You cannot divide the interface between the rectus and the vastus lateralis without denervating the rectus muscle group. So you have to go behind the vastus. It's just like sort of like a posterior approach from the front. Lift the vastus up, and then you can gain access to the anterolateral femur. Start with the episiotomy in the front, which is the blue arrow line on the bottom left side of the screen. If you can't get the implant out with that, complete the wall osteotomy. It is basically an osteotomy that starts over the lateral femur, and you're cutting the anterior almost half of the femur off. You can even do this by leveraging the fragment from its proximal source. This is a picture from Mike Nogler's study from several years ago, and this technique actually works quite well. and allows full access to the implant. This is an example of a potted HA-coated stem that was loose enough to cause symptoms, but fully ingrown distally, that we simply did an episiotomy and exchanged the stem. Probably too many wires, but wasn't sure how many to use, and always feel like extra stability is beneficial. When we're talking about removing the acetabular component, I'm a big fan of the explant device. It's simple, it's easy. When you start using this, start at the pillars of the bone. Don't start anteriorly over the anterior wall or on the posterior wall. That's the thinnest part of the bone. You're probably going to crack that if you start there. Start on the ilium and then go to the ischium and then go to the pubis, because you've got good bony support around those areas. And once you've driven the blade into those pillars, then you can start to connect the dots. And I think you'll find that you damage the bone much less frequently when you do that. And when you take your implant out, the one on the left doesn't have a whole lot of bone on it, but you really shouldn't have much bone on your implant when you take it out. So this is easily done from the front or the back. This is an example of 2 anterior revisions that I did in the past 3 or 4 years for chronic PJI. Pre-op on the left, post-op on the right. The one on the bottom is one of the wall osteotomies. The proximal fragment is never disturbed. So that trochanter is not taken off the proximal femur. The osteotomy is on the anterior side of the bone. That patient's full weight bearing right after the revision and actually has a very quick recovery. So what influence does the approach have on outcomes with revision hip arthroplasty? We just published a study this year. We looked at 290 revision hip arthroplasties that we did over a 7-year period. And understand that this study is not perfect. There was a lot of statistics that went into it. The approach chosen for revision was completely discretionary between my partner and I. Some of that was based on how confident we were with the techniques. With the anterior group, there were no range of motion restrictions after surgery. With the posterior group, we put them on restrictions for 3 months. Wound closure methods were the same. The indication and type of revision, as well as comorbidities, were collected. Regarding stats and outcomes, we tried to control for confounding variables through a binomial logistic regression analysis. We control for age, sex, BMI, and then the type of revision, categorizing revisions into femur only, acetabulum only, both, or modular. And then we looked at outcomes, mainly 90-day outcomes, including inpatient complications, medical complications, transfusions, and the need for readmission. And I apologize for the busy slide, but a couple of things that are important to look at here. The reasons for revision were not completely consistent between the groups. You can look on the left. Those that had psoas symptoms and required a revision for a prominent anterior cup, we approached those from the front by and large. And those with metal/adverse local tissue reactions, we approached those from the back by and large. So you could argue that some of these patients that had worse problems were approached from the back. Please recognize that when we look at the results that we published. And then obviously failed liners and modular revisions were more commonly done from the front. When you look at reasons for, the type of revision being acetabulum, femur, both, or a head ball liner exchange, overall the groups were fairly consistent. The acetabulum and femur combined were a little bit higher in the posterior group. So understand that that's a bigger surgery. And then the head ball liner exchange was a little bit more common from the front because we were on a learning curve trying to figure out how to do this. So here's our data. The instability data was pretty significant when trying to control for those confounding variables. We had a 13% dislocation when we did the surgery from the back and a 2% rate of dislocation from the front. But for every approach, there's a pro and a con. And the con in this was superficial wound complications were significantly higher from the front than they were from the back. But it was interesting that deep infections were not statistically significant from the front for the back. Remember, the skin on the front of the hip is thin. It's less robust than it is on the back, and it does not take a joke. So you got to understand that, and I would argue that using wound management devices from the front probably makes sense in the revision scenario. So with that, thank you.
Thank you very much. Covered a huge amount of ground. That's impressive. And I wish I could only take 20 minutes to take out my stems, but I don't always get that lucky. So I got to get some more magic touch here. Questions. There's a bunch of questions here. I'd like to start with you, Dr. Lewallen, if you don't mind. How hard is it for a non-Mayo or a university lab to obtain metal ion levels in synovial fluid?
Well, I think most places send this to a reference lab. We happen to be one. The ironic thing is on that case that I showed you, patient came from Green Bay, Wisconsin, and the first levels actually were done at our lab. I didn't know that when I saw them. So we repeated them because we didn't trust them, and we got two levels from the same lab. So I think, you know, it can make a difference a little bit, but I think there's mostly good information out there. Wherever you happen to send them, you're probably going to get reasonable information. The problem is they can vary in the same patient over time.
Good. And when you sent yours to the same, both the same lab, did they have the same result both times?
They were drawn on 2 different occasions. One was over 1,000, the other was like 950. So
Okay.
probably within the range of the error for the technique.
Pretty good. Thanks. So so another question from the panelists, and this is for Dr. Bradbury. And, you know, I find this myself when I'm in practice and trying to take out hardware and taking out the femoral stem. How do you keep your instruments from skiving out laterally with the top-down approach? You burr down, you get exposure, you start cutting it, but then it starts angling that osteotome outwards, even with those curved osteotomes. How do you keep it? Do you have any tips or tricks?
Yeah, I mean, I guess using the burrs to help you. So I want to try to create a little bit of a cone at the top. So I'm pretty aggressive with removing bone from the top. So I have the ability to angulate osteotomes toward the implant. And the other thing is a beveled osteotome, right? You always want to keep the flat edge of the osteotome against the implant, the bevels on the bone side. So the bone should help drive the osteotome against the implant. And listen, it doesn't always work, right? We create problems taking these stems out. But I would argue that being aggressive with your burr work up top saves you a lot of problems lower down when you're taking those implants out.
Thanks for everyone for sticking with us. One last question for all the panelists, and I'd like to start with Dr. Melnic with this question. If you're doing a primary total hip replacement after removing a short intermedullary nail for fracture or DHS, do you need to bypass the stress riser with the diaphyseal engaging stem, or can you go standard ML wedge or other primaries? I'd love to see what Dr. Melnic has to say about that.
Great question. So if I'm taking out cannulated screws, I think it's totally fine to stick with the flat or a wedge tapered stem. But if I start taking out DHSs or anything longer, or especially like an intermedullary nail after a intertorque fracture or something like that, I usually go with a short monoblock stem. Try to stay away from the modular stems there.
Okay, makes sense. Dr. Lewallen, Dr. Bradbury, other thoughts?
Well,
Yeah, I
I'll tell
agree.
you,
I'm a
if
big
you've
fan
got-
of
Go ahead.
reaming bone that isn't good quality, broaching poor quality bone. You know, Dr. Lewallen talked about that when he's broaching cones on a tibia. If you're broaching paper thin bone on a tibia, something bad's going to happen. Same thing on the femur. And I think reaming is a much more controlled way. So if I've got suspicion, I'll just go to a short Wagner tapered style stem and ream it because it gives me better control and lets the hoop stresses dissipate a little bit.
Yeah, I think for the fracture fixation patients, remember these people, often elderly, osteoporotic, they break things for a living. And so, you know, putting something in that can split the bone isn't necessarily the best choice always. And so we tend to cement a lot of those people or use a long diaphyseal engaging, you know, fluted tapered type device and then cerclage to protect the upper part of the bone.
Thank you for our series sponsors. So everyone have a good evening, and thank you, everyone.